Thank you, sir. Uh,
Dr. Gajit.
Cataract surgery is the most complication of the VR surgery, and almost 65 to 80% patient require cataract surgery within 2 years of after the VR surgery. And phaco combined surgery is being preferred nowadays in the patients above 50 years because of the such a high number of patients require cataract surgery after vitrectomy. Why this cataract progress fast is because of increased retroreticular oxygen tension, which is causing oxidative damage to the lens protein. There is an altered environment following the vitreous removal. There might be hydrogenic trauma, or we are using the intravitreal tamponade like gas or silicone oil. How we can have a successful phaco post vitrectomy eyes? The preoperative consideration will be one has to do a very close examination of posterior capsule to look for possible rupture of posterior capsule during the VR surgery, and there can be a sign of phacodonosis or zonial instability. The IOL power calculation is always it is be always challenge, and optical biometry will be always a better choice. If cataracts is too dense where the optical biometry is not possible, the immersion ultrasound is utilized. And if when we are using this, it is in a more challenging when we are eyes filled with the silicone oil. IOL selection, again what we are debating, the greater risk of IOL tilt and decentration is reported in recent studies. Hence the multifocal IOLs and the other optically advanced IOL selection should be done with extreme caution if the oil is not that eye is not filled with the silicone oil. When we are doing the what are the intraoperative consideration, the postoperative eyes may have the exaggerated anterior chamber depth due to the lack of support and the low scleral rigidity. So one has to keep what is the solution? One has to keep the infusion pressure low. Then giving the retrobulbar and subtenon block may provide some posterior support. One has to take care of the proper wound construction, and when handling or removing the surgical instrument, it should be removed slowly. One should make the short tunnel to avoid the corneal distortion due to the use of the vertically oriented instrument in the long tunnel incisions. Iris lens diaphragm retropulsation syndrome, or LIRDS. It is because of the laxity in iris lens diaphragm, in which the pupil border may stuck with the anterior lens capsule, resulting in the trapping of the fluid in the front of the iris and thus increase the anterior chamber depth and pressure. So when you are going in, please lift the anterior capsule with your chopper or another blend instrument and maintain the fluid equilibrium. Capsular axis is again challenging, so one can use the trypine flu dye for stunning of the better visualization. One can use the cystatum to raise the flap and then complete the capsulotomy with the forceps. Avoid hydrodissection in the presence of possible posterior capsule trauma or touch during the vitrectomy, and in such situation hydrodelineation and viscodissection are the safe. One should do a very slow and gentle movement while during the surgery, and when if we are suspecting there is a zonial dialysis, one should be take more cautions. Careful and complete removal of the viscoelastic material should be done to prevent the post-operative inflammation and the raised post-op IOP spikes. Sometimes we are having the situation where the silicone oil is in situ and there is a cataract is progress, and the VR surgeon don't want to remove the oil because of the retinal pathology. So there are certain challenges in those particular signs. Sometimes there is an emulsification silicone in the back of the cornea, so one can remove with the use of OVD. If it is simple, some emulsifying bubble, it can be removed very easily. But when there is a lot of silicone oil, one has to because it is because of the hypotony probably. So we can use we should avoid the peribulbar blocks in such situation, or no compression after the peribulbar block, and one should use the continuously use the viscoelastics in every steps. Remove if there is large bubble, one can remove with the phacosuction also, but if large amount is lost, after the surgery, one should supplement it with the more oil. If there is an extensive synechia, Dr. O.P. Agarwal has already covered it well. You should break the synechias and use the viscoelastic, but keep caution not to damage the anterior lens capsule. Non-dilating pupil again is a challenge. So you can use the mechanical pupillary stage by injecting more additional viscoelastic, or use Y-shaped iris spatula or pupil expander, like the things one can use. There is a shallowing of anterior chamber because of the silicon oil is lighter than the intraocular fluid, and it is floating anteriorly, which is pushing the posterior capsule. So use a good amount of visco always after every step, and remove the surgical instrument very slowly. There, because of the silicon oil, the posterior capsule will be capsular plaque will be very dense. So don't try to remove it. Don't try too much to remove it, and one can use the yak capsulatum in the later on. IL power calculation is again challenge. Optical biometry is the choice, and if you are using the ultrasonic biometry, you can multiply the axial length by converse section of 0.71. So there is a small video. If we are not having time to, I'm not showing that, but it's just 30-second, 40-second video. There is a bubble in the anterior chamber which we are removing just with the infusion cannula. And because we have seen so many video and we are having two more talk, I'm skipping this. So to conclude, phaco in the post-vitrectomy eyes with or without silicon oil is a challenging situation, and it can be managed successfully by modifying some surgical step for the maintaining anterior chamber stability. Thank you so much for patiently.
Thank you, Dr. Chawla. Only a good manager can do it. That's skipping the part of the video. Thank you so much.
Thank you, sir. Sir, being the leader of the MP State Society, I have to take the care of this.
Thank you so much.